Right. Today, we have our speaker, who is Dr. Jones, is a Jamaican national who graduated from the Knox College in Jamaica in 1978, and then pursued his undergraduate education at the University of Nebraska, Lincoln, United States of America, from where he graduated with a degree in life sciences in 1983. He then entered the Howard University College of Dentistry in Washington, D.C. to pursue his Doctor of Dental Surgery degree, which he completed in 1987 and then returned to Jamaica shortly thereafter. Dr. Jones was employed to Government of Jamaica's Ministry of Health from 1987 to 2011. First as a dental intern attached to the major trauma institution, the Kingston Public Hospital, then as a dental clinician attached to the government's dental clinic in central Jamaica, and then since 1996 at the government's dental auxiliary school in Kingston, where dental therapists, assistants, hygienists, and technicians were trained. He served first as a lecturer and clinical and laboratory supervisor, and then combined those duties with those of being the school's director from 1998 until the school's closure in July 2011. Dr. Jones was a member of the Dental Council of Jamaica from 1999 to 2011 and served the Joint Committee of Tertiary Education of the University Council of Jamaica as a member for one term. Dr. Jones joined the Faculty of Medical Sciences, School of Dentistry of the UWI Mona campus on August 1st, 2011. His particular interest in dentistry lies in dental education, curriculum development for dentistry, dental ethics and jurisprudence, dental simulation, forensic dentistry, and social accountability in dentistry. Today, he is going to give a talk on his topic. I welcome Dr. Jones now to take the floor. Thank you, Dr. Jones.
Okay, thank you. Good afternoon, everyone. Members of the IADR Caribbean section, members of the dental profession. So this afternoon, I've been invited to speak to colleagues and fellow professionals on a topic that is central to dentistry going forward, and more will become a part of dentistry for future dental students to be taught under. So the title is Dental Simulation, a Bridge to Clinical Competency. And today I'm going to take you through a journey of what we have been able to do at the Mona School of Dentistry in an effort to bridge this separation of clinical competency from preclinical competency. So as all of us know, dentistry involves acquisition and maintenance of fine motor skills. The focus of these motor skills are primarily movement-oriented skills, which require, as we know, focus, concentration, and over time, as we develop competency, they become automatic. So at the Mona School of Dentistry, our program centers in a course called the Dental Practice course. It is a year one course in our old 2-3 curriculum, and it going forward is going to be one of the first courses that students do in year 2 after a year of basic medical sciences. So the course looks at 3 areas in trying to bridge this gap. One, it looks at augmenting students' transition into their competency-based courses. 2, it assists them with the challenging, and we know it is very challenging, transition from the basic medical sciences to the clinical dental sciences. And thirdly, the course looks at introducing to the students clinical practice indirectly through the use of simulators. And how is this done? Here's an image of our advanced simulation lab with our integrated software to our dental simulators, where students practice in a simulated clinical setting. We say to each student, treat the simulator as a patient. So students interpret that in a very good way, where most of them will name their simulator, give them a name, and each day they come in, we guide them. If you treat them as a patient, when you come to treating your real patients, the only difference that you will have is that the patient who you will have in the clinical setting will be able to speak back to you. So we use practical and simulated clinical settings in this lab to help them to develop competency before they can deliver direct, comprehensive patient care. So for today, we have 2 main objectives. The first objective is to value the development of critical thinking skills when using dental simulation. The second major objective is to understand the role that simulation plays in students' self-evaluation of their performances in laboratory procedures. And then we have a secondary objective, which is to relate proper intra-oral ergonomics to enhancing the development of clinical competency while performing selected cavity preparations and patient care procedures. So we have 2 main objectives and 1 secondary objective, and we do hope to be able to meet them by the end of the presentation. So to get us all started with the language of simulation, there are 3 key terms that will come up during the presentation. The first one relates to VRBT, which is virtual reality-based technology. The second one is DSL, which is directed self-learning. And the third one is PECT, psychomotor, ergonomic, and critical thinking. So I'll be interchanging between the abbreviations and the full term throughout the presentation. And there are key terms in understanding how simulation is applied to developing clinical competency. So we want to give you some background into our program here at Mona. The program started, the undergraduate dental program started in 2010. In 2011, we looked at a revision of the program, looking towards how dentistry would be evolving over the next couple of years. And in our research, it led us first to the University of Pennsylvania, and then it led us to the University of Minnesota. And the key person connecting those 2 institutions was Dr. Judith Buchanan, who is one of the leaders in dental simulation throughout the world, not just in the United States, but throughout the world. And we paid a visit to her when she was the acting dean at the University of Minnesota. And we toured their lab, and we got to understand how they have integrated into development of their clinical competencies. So from that visit, I think that visit was in 2012, we actually worked with a regional supplier and one of our undergraduate medical students who worked for that company to open 2 simulation laboratories in 2013. Both laboratories have ADEX simulators out of the United States, and one of them is equipped with the VRBT software. So from the acquisition and opening of those 2 labs, what we now have today are, in our basic simulation lab, we have 26 simulators, which are akin to the conventional learning that we normally would do in dental school, where an instructor, you present your work to an instructor, they give you feedback, you go back, make the corrections, come back to the instructor. So that's what is in the basic simulation lab. We have 25 simulators for students and one is a teaching station. Then in our advanced simulation lab, we have 8 advanced simulators. These are the ones that are integrated with the Densim computerized VR-BT software. Very interestingly, the Densim program actually originated out of Israel. And through a dedicated information technology network, the DenX company, which originated Densim, they actually monitor and maintain our software system. So our lab is housed in the building on the left on the screen, and from Israel, the maintenance personnel will work with us, time zones notwithstanding, to maintain and keep our equipment as efficient as possible. So what really happens in the lab? So first, when students come into the lab, they are presented with this home page. Each student will have their own individual login, and then they will log into the Densim program. When they log in, they are greeted with a screen that gives them 4 options. Lessons are pre-planned options that we would have set for the students to accomplish. Practice means they can come into the lab and spend any amount of time that they wish to practice before they have an assignment, which is the term the Densim program uses to convey that they have an examination. And then they also have the option of going to a previous session. So each time they work on the system will record what they have done in real time. They are able to play back the session in real time, meaning that when they play back, they can stop, they can zoom, they can look at where they went wrong on the evaluation screen, which I'll show you in a minute. So it's really an active type of review, not the old time VHS type of recording where you just can play whatever was recorded. So in the lessons, we will then show them a page like this, where we would define the cavity preparation. In this case, it's a class 1 occlusal on tooth 4-6, the mandibular right first molar. It identifies them for the course that they are in, which class, and which lesson they are going to do. It also guides them as to when they can start and when they can finish. And very importantly, it gives them a time limit in which to complete the procedure. Now, as you know, competency means you are doing a certain skill at a certain level in a certain time. And as they develop competency, this time period would decrease if they're doing the same procedure over and over. Now, as I mentioned earlier, the system tries to get the student to understand, or try to get them to understand, that they're working on a patient. So in addition to just identifying the tooth on a screen, and you can see the tooth identified in yellow, they will present an X-ray to get the student to understand that if it was a real patient, then they would be identifying the lesion on the tooth itself, and also they would have to view an X-ray. So this is how the students are guided. And in developing competency, we share with them, okay, for each lesson, you can do 1, 2, most likely, we give them 3 opportunities to do the same lesson before we say to them, you can move on to the next lesson. And then at the end of the course, they will be tested in one of the assignments, where we normally bring back the same procedure, and we expect them to perform it at a higher level, having done it at least 3 or 4 times before. So when they click on the clinic icon at the bottom of the screen, they will go into this page, which is basically their working page. And again, the system tries to show them that they're working on a real patient. So it gives them 2 images on the left. The upper image is their starting image. Those 3 green areas indicate caries, which they will have to remove. And when they remove it, they get a nice sound on the system. The system works by sounds to give you feedback. So good sounds mean you do something good. Bad sounds, like exposing the pulp, you get a very big, loud bong. And students don't like the sound and sometimes ask us, please, to turn off the bad sounds. but they get the good sounds, so they have to get the bad sounds. So in the image on the lower left, that shows the preparation that they are intending to do. And then on the right, it shows the intra-oral image, focusing on the tooth, in this case it's 4-6. And then once they take up their handpiece, then they now see the handpiece inside the mouth. So as they work, they can see the handpiece moving in the patient's mouth. The challenge that we have is the students who are very good at video games. They will watch the screen and watch their hands move and cut the preparation. And we tell them, yeah, that's fine. But when you go to the patient, there's no monitor. So please get used to looking at the tooth, looking in the mouth. They do this very often when they're working on the upper arch, because indirect vision, as you know, is the most difficult of the skills to develop in dentistry when you're working inside the mouth. So they will see the handpiece move, they will see themselves cutting the prep. And if you look in this particular case, you can actually see where this student is actually close to the end, because if you look on the top left-hand screen, you can actually see the dentine beginning to appear. That's that yellow color seen on the pulpal floor on the upper image. So where the dentsim helps them a lot, and where the difference is that the research shows, is in the evaluation screen. In the evaluation screen, which is shown here, the students actually see the tooth in different cross sections. So they're actually cutting the tooth and looking in areas that we would never see at the natural tooth. And it actually shows them how the pulpal floor will change going from mesial to distal, how the slope will change, where you would cut differently if you're in a fossa versus along the central groove. And it gives them a lot of variety of feedback. The research has shown that the more students spend time in the evaluation screen, is the better they will learn. And when we do evaluate the students, because they're just being introduced to dentistry, we spend time to say to them, we are not evaluating you on the preparation itself. Where we're evaluating you mostly now is the number of times you go into the evaluation screen. And there are certain ratios that are standard that the research has shown that the more you evaluate, the higher your score will be. And so we ask the students to spend as much time as they can in the evaluation screen, and based on the results of the students, we see where those students who spend more time in the evaluation screen are the ones who get better grades. So those are the basic steps for the simulation program that we have. So we move to the next area, which looks at the different procedures. So in our school, we have two types of focuses on the technology. When we first started, we had a singular focus, which was VBRT in that advanced lab using the dentsim software, where all the students did before they went into their competency-based amalgam course, composite courses, oral maxillofacial surgery, pain management. All they would have done in terms of simulating clinical practice would be in the dentsim lab. We have moved now to a more multi-focused approach to developing their simulation, from simulation to clinical competency, where we now have VBRT and non-VBRT simulation. So as I just said, in the dentsim software, the key is self-evaluation. That's where the students develop their critical thinking skills. And it's because they get direct and immediate feedback. As we said before, the usual way of developing competency is through the instructor feedback, which if you're in a class of 20 or more, you would have to wait in line to get feedback from the instructor. So if you can self-evaluate your own preparation, and develop the confidence in doing that, you should be able to move further along the pathway from preparation to finish than those students who don't have the same level of critical thinking skills. As I said before, the tooth preparations can be sectioned. We can see inside the tooth. And in learning to see inside the tooth, if you can internalize that, each time you will then cut a preparation, you will then be able to see inside the tooth and know whether you have cut the pulpal floor at the level it should be, whether your line angles are as sharp as they should be, whether your convergence is as it should be. And again, if you start them off with VBRT, then you will be able to help them to move into the regular laboratories and be able to move them from those laboratories to clinical practice so that they will have the required competency. So another research link, we spoke to about Dr. Buchanan first. This is now Dr. El Haddad out of Israel. He is from the DenX company that has manufactured the Densim. He's based in New York now. He has a Densim laboratory there where he opens it up for dental students in schools in the tri-state area. So in his research, what he did, he had two groups of dental students. He exposed group one, to the Densim program, where they had access to all the Densim evaluation and visualization features so that they could assess their work and get direct feedback. And as shown before on the previous screen, the grades for the dental simulator are automatic. As you cut, students sometimes are a bit amazed to see that their grade can go up, down, sideways during a simple procedure, because each time that they cut, wherever they cut on the tooth, that is evaluated by the software and then the grade changes. So that was group one. In group two, they had an instructor who would guide them in the normal process, which is you work, you show the instructor, you get the feedback, which most likely is not immediate because you'd have to wait in line because you're in a group. And then you would then proceed to follow the instructor's guidance, make the corrections, and then you will move on to the next phase. So in group two, all the Densim evaluation features were concealed. So what did his results show? His results showed that in each group, their grades did increase. So he had 4 sessions, and from session 1 to session 4, the grades increased. So we had group one that were being evaluated and given direct feedback by the Densim program, and group two, they were given feedback from the instructor. Where the differences occurred out of his research was that in group one, those who used the Densim program, their grades were higher. Their learning curve kept on the increase, and they achieved a higher level of competency, which you can translate to mean that in the same amount of, to get to the same grade level, they would have done it in a quicker time, moving from session 1 to session 4. Group 2, who did not have the Densim program, their improvement was seen, but after a while it plateaued. So we have said to ourselves that we want to see if our students have the same type of outcome. So we have had 9 cohorts go through the program so far, and we have started the research on it. Hasn't been concluded. It tends to support what he has reached, but we'll wait until another 2 or 3 cohorts before we'll say we have had enough students pass through the program to get a good number, because our class sizes are between 15 and 20. So we're trying to see if we can get to that critical number such that the results can be validated and be reliable. So from Dr. El Haddad and his research and our other research, we have now 2 phases of simulation technology in the school. The first one deals directly with the lab only, where they will develop all of the skills, psychomotor, critical thinking, and ergonomics, and using the Densim software as the base for this type of simulation clinical competency development. And then in phase 2, which is where we are still in the developing stage, we have not really integrated as well into the timetable as yet. We now have 3 non-VBRT software related simulators, sorry. So the one on the left, in the upper left, is our LA simulator. This is where students practice on the simulator to deliver their different nerve blocks. You can deliver inferior alveolar nerve block, posterior superior, nasopalatine, mental, all the different nerve blocks can be delivered. This is both immediate feedback and instructor feedback. The immediate feedback comes when you deliver the inferior alveolar nerve block and the middle superior, anterior superior nerve block. If you look on the image on the left, you'll see a small circle in the middle of the forehead. This is an indicator that lights up when the student hits the inferior alveolar nerve or hits the middle superior or the anterior superior nerve block. So students, in practicing on the simulator, they will see directly if they have placed the needle in the position anatomically where the middle superior nerve block should be and where the inferior alveolar nerve block should be. We are still researching to see if they have taken this simulator to the next level, which is where more nerve blocks will be indicated by the green light going off in the simulator's head. Then you go to the upper right, which is our second simulator that does not use software. Sorry. This one is our X-ray simulator, and our simulator, in naming, giving them a name, this is Dexter. So Dexter is our most used simulator outside of the DenSim lab. For Dexter, you can see inside the arch, there are different pathologies in each arch, and there are also impacted teeth in each arch. So before the students get to work on patients, we guide them through the use of this simulator in taking their imaging. And then the third simulator that we do have is our basic patient simulator torso, where both in an individual basis and in four-handed dentistry, students learn how to position themselves around the patient. All of the simulators here can be attached to the dental chair. So we try to help them to attach them to the chair to simulate actual clinical practice rather than put them on a chair that is not mobile. So with this third simulator, students practice the different positions to deliver anesthetic, to do their x-rays, to examine if you're right-handed or left-handed. And then when they get to do dental auxiliaries utilization course, then they learn the different zones in which operator should be, where the assistant should be, and how to transfer the instruments. So after the students have practiced, the next phase is how do you get them now to be assessed? So as I said before, the lessons are predefined by us, helping them to develop their competencies. The students are able, under the practice session, to come in, select any preparation that they want, and they can practice as many times as possible without affecting their grade for the lesson. And then at the end of the course, we will give them their assessment under the assignment icon. We will select normally the same preparation and have them do it over at a higher competency level. Whereas they can do the lesson 2 or 3 times, whereas they can practice many times more than 2 and 3, they only have 1 opportunity on the assignment. And then we will evaluate their results. As I said, as they develop competency, what we are looking for is, have they also developed the critical thinking skills by spending more time in the evaluation screen. So as we said, we had a minor objective of ergonomics. So we actually test the students in how they are developing the proper ergonomics needed to support a long time in dentistry. As all of us know, and as the research proves, dentists normally do not stop practicing, or anybody who practices dentistry, you know, the dental hygienist, the dental nurse, all of us who are operators, we don't normally stop practicing because of, yes, you know, we reach a point where we want to stop. If we are forced to stop, it is because of a musculoskeletal problem. Because over time, we forget the proper ergonomics, we start to lean over to the patient, we then have a difficulty now in our body responding to what we needed to do as we get older. You know, my goal to the students is I tell them, last time I checked, you only had one back. So preserve that one back, because if you don't, you're going to be forced out of dentistry before you want to. So there are 4 key principles to proper ergonomics in dentistry. The first one is to ensure that the middle of your back is supported. So in our course, what we will say to the students is we spend at least half of a session teaching them how to adjust a dental chair. Because what students will do, and what some of us will do too, when we go into a multi-chair dental space, instead of trying to adjust the chair, we try to find the chair that's already adjusted for us. So we guide the students that you need to know how to adjust the chair so that you can get the back of the chair to support the middle of your back, not your lower back, not your upper back, but the middle of your back. The second principle of ergonomics that we teach them and evaluate them on, because we have a rubric that specifies how often and how well they're doing these different 4 areas. The second one is your knee should be parallel to the floor or just below parallel to the floor. And then the third one is the nose-to-nose distance is maintained. Now, this is a distance that one of our lecturers guided us on when they first came. And it's quite simple. If you place the thumb of one of your hands on your nose, spread your fingers, as I'm trying to do now on the screen, put the thumb against the middle finger here, like this, and then evenly spaced fingers, your little finger should be touching the patient's nose. So we remind them that this nose-to-nose distance is an easy way, using your 2 hands, to know how far away you are from your patient. And each time we start a lesson and we focus on this part of ergonomics, we say to the student, your body is going to go to where it wants to go. So all of them sit upright, all of them have their back supported, and as the procedure moves from 0 minutes to 30 minutes to 40 minutes, you can see their upper back going closer and closer to the patient, i.e., they are reducing their nose-to-nose distance. And then we'll say to the student, we'll point it out and say, please get your eyes checked. You may need to get a new pair of glasses, you may need to get glasses to maintain the nose-to-nose distance. And we tell them, if you like loops, dental loops, this is a reason why you may want to get it, to maintain the nose-to-nose distance. So that's the third premise of ergonomics that we have them follow. And then the fourth one, which is very important for your posture and for maintaining the health of your back, is that your feet need to be flat on the floor. Students will move their feet unconsciously. We start them off with feet flat on the floor, and before you know it, it is on the chair. And for all of us who are up in clinical dentistry, when you go back to your offices, check your feet. What are you doing with your feet? Are they flat on the floor throughout the procedure, or do they start to dance? We have some dancers in some of our classes, and after a while, you see the feet start to dance and the tap dancers come out. But you really need to be able to keep your feet flat on the floor to maintain proper ergonomics. So these 4 principles is what we also watch when the students are developing their competency by doing the cavity preparations on the simulators. So this just shows you the position, how you want to be successful in ergonomics. It shows the middle of the back being supported. It shows the knees being just below parallel to the floor. It also shows, if you look at the 2 dots in the head and the shoulders, that straight line is how you want to be able to focus on the patient. You don't want to be bent too far over. That's going to put strain on your neck muscles. And this is how we guide the students. And also, in this position, you can see the angle between the lower arm and the upper arm. also a good way to maintain proper ergonomics. So as we look at the intra-oral side where they're cutting the preparations, we're also looking at how simulation needs to be joined with ergonomics. And these 5 areas are areas that we check to make sure that the students are developing these characteristics. 1, relaxed shoulders. 2, straight back. 3, if your feet are flat and it's just below parallel, then you'll get proper circulation in your legs. If the chair seat is too high up, you're going to cut off some of your circulation. And then 4, if you maintain 1, 2, and 3, then you're going to have healthy hip and knee joints. And then most importantly, feet are flat on the floor. So that is the minor part of what we try to do, is watching their ergonomics. So as we come to the close of our presentation, we want to guide you as to where we have been and where we're planning to go. So in our simulator, in our advanced simulator lab now, the students will prepare 10 to 20 teeth per course. And before they get to comprehensively treating patients, they will treat between 70 to 80 teeth in the various competency courses leading up to clinical practice. More and more patients do not want students to practice on them. So the more they can practice on artificial teeth, though it's not the same, we will guide the students that at the end of their preclinical courses, they are doctors of dental mannequins. And then when they finish their clinical practice course, then we will say to them, no, you're doctors of dental surgery. Because the difference between a doctor and a dental mannequin and a doctor of dental surgery is the tongue. No tongue, you can consider yourself a master of working in a patient's mouth. Introduce a tongue, it's a whole new ballgame. So through virtual and direct simulation, we try to allow the students to develop confidence in their abilities. From there, we move to the non-BBRT simulators, where in the amalgam course, the composite course, the coronal restorations course, endodontics, periodontics, and minor oral surgery, they will work on the different simulators we mentioned, where they will develop these competencies now without the support of the software. The third area where we are trying to go is the next generation simulators. As we try to deal with the millennial student, their learning styles are completely different than what most of us who have been in dentistry for 20, 30 years were used to. And as they have shown us how they learn, we have had to adapt information technology and simulation to develop a next level simulator to which they will be more comfortable with. And this is the next level of dental simulation, virtual reality or haptic simulation. So the research findings, when you put all of this together, state the following. 1, when you have the software integrated simulation, you actually have feedback on demand. Normally, we get feedback because we have to wait in line for the instructor to tell us, show the instructor, let them review it, and then guide us. With the software, you get immediate feedback. You compare this when they are practicing, they can practice repeatedly. You could never practice repeatedly on a patient because you have to appoint the patient, bring the patient in, and then you practice. With the software, you can now practice over and over again once you have the required number of teeth and you don't have to worry about appointments. When you look at the grades that are produced, the grades are higher once you learn how to develop the competency on the simulator, because you're now able to critically think more such that you can now do self-evaluation. And in dentistry, the idea of students assessing themselves formally is one that is also on the increase. More and more dental schools are including self-assessment where students independently, using the same criteria, assess their own work before the instructor comes and assesses them. Thirdly, the use of 3D, three-dimensional imagery is a plus to this generation. All of them can play video games. You know, they manipulate keyboards as if there was no separation between the letters. And using the three-dimensional imagery matches their type of learning style. 4, unlimited self-assessment, as I said, through the various practice mechanisms. Faster learning because you are now able to practice at your own leisure, timetable permitting. And as shown by Dr. El-Haddad's research, those who use the technology, their level of learning increased faster. And also, based on his research and other research, it is easier to acquire the skills needed because you can focus on cutting the preparation on the simulator without having to interact with a patient who may be uncomfortable and needing for you to spend time making them more comfortable. So in all of this, we do have limitations in our simulation program in trying to bridge the gap to clinical competency. The first thing is the cost of the teeth. The teeth are not cheap. And what we have tried to do with the manufacturers is to say to them, can they put more than one procedure on a tooth? The 3-7 tooth in our program that we have is able to accommodate class 1 single surface occlusal prep, a class 2 two-surface preparation, and also a buccal or facial preparation. Now, when you put those 3 procedures on one tooth, then you can see how it is beneficial to purchase that tooth over another tooth where you can only do one preparation on it and then you have to discard the tooth because it cannot be used again with the software. So we are working with them to get more teeth like 3-7 where we can do more than one procedure such that the student can maximize their own spend and spending of time in the lab, and we can maximize our spend by having less teeth to purchase but having more procedures to do. The second limitation that we have is, as we said, the stations are monitored by the DENX team in Israel. Now, the sensitivity of the system is something that we were not aware of initially, but we have learned that we actually have to calibrate the stations, calibrate the software to make the grading as accurate as possible each time the students come into the lab. So this challenge of calibration limits how efficient and how the students develop confidence, because if it's not calibrated correctly, they lose confidence in the software. So we work with the persons from Israel and we work with our own IT persons to see how we can keep the calibration up to par before each session. And the third limitation that we have is that in order to practice on your own, you need time. And as we know, dentistry is a packed curriculum, it's a spiral curriculum that keeps on adding more and more. So we are challenged with finding the time during the week. You know, we have explored allowing the lab to be open on the weekends, but COVID put pay to that. Now that we're coming out of COVID-19, we're going to see again, we have a maintenance personnel support challenge on the weekends also. But that we see is the solution going forward for the timetable challenges, to allow them to come in on the weekends once we can get the maintenance support for the building to be opened and for the compressor to be turned on, because the more they practice is the better they will become at using the system. So we have some limitations, but we have a challenge. The challenge is how to convince students that the simulator is a real patient. It is where we find that the research shows that moving from the simulator, if you had done it as prescribed, all you really need to do is make a 180-degree turn and you're at the patient, and just all you have to know master is the tongue. With the use of rubber dams, you can master the tongue, and you can then monitor the patient. But students, for the most part, don't understand this value of the simulator being a patient. So when they reach to the patient, it's like starting over. And they don't understand that if they had focused more on maintaining the skills from the simulator to the patient, that transition would be easier. So yes, we tell them to treat the simulator as a patient. Yes, we tell them to call it, give it a name. We ask them to wipe down the patient, clean out the mouth when they're finished. There's still a gap there in getting them to fully understand that the simulator is a patient. So that's our challenge, to build their confidence with the simulator, to make them understand it's a 180-degree transition to the patient so that they will not be as afraid and apprehensive when they do get to treat patients on a day-to-day basis. So I mentioned the future. The future is actually now. So between the Moog Corporation and ACTA, which is a dental school in Europe, they have developed the next generation of simulation, the haptic virtual reality-based simulation. So in this image, this is an image from one of the students in ACTA, where they are focusing on their virtual reality dentistry. So the monitor on the right is where they use to select the preparation, the handpiece, the drill, the mirror. And then when they put on their glasses and look through the virtual window, they actually see what we would be seeing inside the patient's mouth in our lab. The beauty of this next level simulator is you no longer have to buy teeth. You no longer have to buy handpieces. You no longer have to buy burrs. Everything is in the virtual space. And as I shared, the millennial student really appreciates this type of learning. The traditional learners and traditional dentists have a challenge with this because they say it does not really simulate working on the dental working on the typhodont. But based on other research done, based on usage, they actually feel similar pressure moving through the virtual enamel into the virtual dentine. And the technicians and the computer technicians continue to work to improve this system. We have this as one of our goals, is to try to see how we can afford at least one or two of these units going forward, because that speaks to the next level, speaks to the millennial, and helps them to better transition from preclinical dentistry to clinical dentistry. So for us, we have not reached that level, but our next level uses what we do have. So on the screen, you will see 4 different types of attachments. We presently use the 2 on the far right and the one next to it. You can recognize the regular dental handpiece, and you can also see a handpiece that's turned upside down. That is the Densim handpiece. That is the one that is connected to the software and picks up what the student does. We are just about at the point where we can now introduce into the Densim program, into the advanced lab, periodontal scaling and composite restorations. And the idea behind this is, again, you want to be able to give the students as much exposure to the use of these instruments ahead of clinical practice. And we are just one vacuum system installation away from ensuring that this next phase for us, for our way forward, is in place. So in closing, we have tried to bring you through our program of basic simulation using a simulator, trying to bridge this gap to clinical competency. Patients don't want students to work on them, but simulation, if developed correctly, if integrated correctly, will bridge that gap. We continue to work with our students. We continue to see and look at the research that is being produced around the world to see how we can better develop this form of clinical competency development. These are the references, Dr. Buchanan and Dr. El Haddad. And thank you very much for your attention. And thank you, Dr. Santosh and your team for inviting us today.
Thank you, Dr. Jones, for that brilliant and straightforward presentation on the modern dentistry. So I would like to welcome the participants to, if they have any questions, you can ask question or you can type the question. In the meantime, I would like to ask Dr. Jones to look at the comment that was received in the comment box and probably can share it with response. We're able to see Dr. Jones.
Mm-hmm. Yes, the comment says, is that the comment where we can try to preserve the back, but we have to be cognizant of the fact that we are sometimes given chairs that are not conducive to the posture of our back or body. That's the point, Dr. Santosh?
Yes, Dr.
Yes. So I am in full support of that, which is why whenever equipment is being purchased, whether in a private office or in a public clinic, we have to stress that we need the proper chairs. One of the things that we found was when we were trying to select chairs, we understood the importance of ergonomics, and we ensured that in working with the supplier, we wanted to get that chair that the students would understand. If you have a chair like this, your time in dentistry is going to be longer. I said the studies, the research shows and concludes that we do not stop working if we want to continue working, if we have the right equipment and support. And we sit in that chair 8 hours a day or more. We need to make sure that in a private office, we get the proper chairs. If we're in a public Ministry of Health situation, wherever we are in the world, we need to get them to make sure that we have the proper chairs. The handpiece, you may have variations there that you can deal with. But if you're going to sit in a chair for 8 hours a day, you need to make sure that it is the correct chair.
Thank you, Dr. Jones. Participants, Dr. Jones, you have a question. How will loss of electricity and internet affect such a beautiful time improvement? Oh.
Yeah. So, right. So the next question, thank Ms. Hedman. How will loss of electricity and internet affect such a beautiful time in the program? Well, very good point. That was one of the points that was stressed to us, both from the manufacturers of the simulators who came down to install them, and also from the DenX company in Israel. As you can imagine, and has been said, if we lose electricity and internet, there goes our program. So in developing the program, our IT section worked with the DenX and the ADEC engineers to ensure that we have an uninterrupted power supply inside the lab. So that's how we solve the loss of electricity. That once our batteries are powered, our UPS batteries are powered, we will not lose electricity in the lab. And for the internet, what they did was they gave the DenX company out of Israel a dedicated and secure line into the university's network. That had to do with internet challenge of you're not to allow an outside person into your system. And they had to find a way to do a closed loop access where they could have direct access and also be able now to have this uninterrupted internet supply so that they are the only ones on that loop. As we know with internet, you may have the best internet provider and supply, but if you have too many people on the network, then you're going to lose the speed that you need. So that's how we have addressed it. And it was with working with both suppliers to know that we needed a UPS system and a direct level of internet support. for the system to work.
Thank you, Dr. Jones. We have a follow-up question from Dr. Hedman, but won't it affect the participant on the other side?
Well, there was another one from Dr. Marshall just before that one, Dr. Santosh.
Yes,
Let me take that one. Thanks, Dr. Marshall, for that question about conducting research on how it is translated to the clinical management of the patient. That's the next step in our research. As I said, we're trying to see how we can get to that critical population to study that will make the results similar to Dr. El Haddad's. We hope that in the next 2 years, we'll have had that level of patient data pool, and then that's the next step to see, you know, how does it translate directly into the clinical management of the patient. What we have seen anecdotally is that the students who perform well with the ergonomics and psychomotor skills are the ones who have easily transitioned to managing their patients. But again, it's not evidence-based, it's just anecdotally, and we do hope in the next 2 years to move to that next level of research.
We have questions from Dr. Williams and Dr. McKenzie. Dr. McKenzie is asking, sorry, Dr. Williams is trying to ask you, transitioning from a simulator to a human person may be a challenge. The curriculum consists of customer service and human related components. So human clients will receive quality, friendly services actually.
Yes, thanks for that. And yes, we do tend to look at that aspect even more importantly as they transition, because in both our dental ethics courses and our patient-based courses, we stress to the student that it doesn't matter how good your hands are. We actually tell them that you go to school for 3, 4, 5 years, 4 to 5 years for dentistry, and you spend all this time learning how to do a preparation, how to do a cleaning, how to do an extraction. But if you can't get the patient into the chair, you will never use your left and your right hand. So we guide them that, you know, their posture, their approach to the patient, their face. We tell those who don't smile readily that you need to change your smile, you need to change your face. You need to know how to approach the patient as not as a soldier, but as somebody who is friendly. So yes, we do take it into consideration, because in the end, dentistry comes down to a one-on-one relationship with your patient that only is genuine if you yourself are genuine.
We have one last question from Dr. McKenzie. What is the cost like to acquire the technology? And in getting uninterrupted internet supply, was there any increase in the cost of acquiring the technology?
Okay, so for both questions, the acquisition of the program at the time, and I think would still be, is quite expensive. But what we said to the university was, if we are going to be in a position 10 years from now where this technology is going to be more widespread, then we will need to make an investment now. So at the time they agreed with us, and all of us know that dentistry is by far the most expensive of all the health sciences, but the payback on that expense has redounded to us, especially when you're developing a program and you know you won't have the necessary human resources available in your country initially. So where you have the technology, it actually helps you while you develop your human resources, because instead of having a facilitator who is inside the DENSIM lab with the student who is a dentist, you actually basically need an IT person in there to monitor the information technology. And that's what Minnesota actually does. You know, they just had a IT person stationed in the lab to work through the calibration issues. Because of the feedback, you don't need anybody there. So yes, it is quite expensive. That's taken us a number of years to pay it off, but the benefit has been very positive.
Okay. Thank you everyone for the questions. I'm not seeing any questions here, Dr. Jones. So I would like to ask a question here. So we know that from your presentation, the activity that the system gives is from the instructor base, like a prepare a class 1 or a class 2. So my question to you is that, does the system allow to make any case-based simulation, like where it can give a case story and the students identify whether it has to be a class 1 or a class 2 or even a endodontic treatment or whatever it is. So is there any system like that? Thank
Right.
you.
Thank you, Dr. Santosh. Presently, there is nothing in the program that allows you to basically do a differential in the case. To say, okay, here's a case, and then determine what procedure you should do. What the system does have, and that's a good question because we can also ask the manufacturers about that. Do they have that as a plan where you would be able to have options to select the procedure based on how you have interpreted the case? What happens now is that each case or each lesson comes with a case report where it tells you, here's your patient, gives you an age, tells you what has happened, and then it guides you to say, here is what the lesson is going to be. So they have started that process, but it's not at the level where you can now have a differential as to which option you would choose. But we will ask them. That's a very good point of developing their critical thinking skills going forward.
Yeah, because as we see that the students, as they move on to the final years, we have to make them to be ready with the problem-based education. So thanks a lot, Dr. Jones. And thank you all the participants. If you have any questions, we can still go on with 1 or 2 questions. If not, we would like to end the presentation. Before we end, we will give the certificates. I'll just wait for a few seconds or a few minutes for your questions. Thank you. So thank you, everyone. There's a reminder here. Please make sure that you fill the forms and you will get a certificate. And there is no CE points. We are working on it. Our next presentation will have a CE points. It is going to be a global webinar. So I will share that screen shortly. And Dr. Jones, on behalf of IADA Caribbean section, we would like to present this certificate virtually, and we will share the certificate later by means of email.
You're most welcome, Dr. Santos. Thanks again for inviting us.
Thank you. It's our pleasure, Dr. Jones. So, right, as I said, before we end, we would like to share the next presentation. That is going to be August 11, that you can see it on your screen. And it's going to be at 11 o'clock. And its presentation going to be deliver the topic on insights on the Eliseo oral microbiome. So this is a global webinar, and it has a CE credits. We will send all the details through the email. So we request you to send your email address in the Google form. Thank you, everyone. The meeting is closed now, and it will be ended now. Thank you. Bye-bye.